Assalamualaikum. So we have the topic on pediatric fractures and fixation, which we are going to discuss. This topic is particularly important and has an associated association with the pediatric age group. The specific reason for including this as a separate entity to adult trauma and fixation is that the pediatric musculoskeletal system is comparatively different from an adult musculoskeletal system. The first and foremost reason is that the pediatric musculature is in progress of development. There is a significant growth which leads to certain differences as compared to adult fractures. The common reasons for pediatric fractures include um, fall, motor vehicle accidents. This is particularly important with children falling even from a small height or like just at the house, falling from a table or bedside, include significant damage. Motor vehicle accident or high trauma injuries, which can cause significant damage to the bones. However, there is very good remodeling potential in the pediatric age group, and hence non-operative treatment holds significance in pediatric fractures. Just taking this for an example, this is an example of a pediatric radius fracture. Now, we need to consider a lot of things when we see a pediatric fracture or a pediatric musculature. This fracture of distal radius, as can be seen, is not a complete or a fracture line passing through it. That is not appreciable. First and foremost thing which we need to see is that how far it is from the physis, because physis is the area which is growing. The next point is the type of fracture. Now, in this condition, it's a compression fracture rather than a complete and a displaced fracture. This is quite unique to pediatric age group because of the fact that the pediatric bones are comparatively very spongy and they interdigate into the woven bone. If we recall the anatomy of the bones, because of this reason, they do not displace completely. Secondly, one thing which needs to be remembered is that the ligaments tend to be much stronger than the bone in pediatric age group. Hence, dislocations are very rare as compared to fractures in pediatric age group. What is remodeling? This is particularly important to understand. Just considering this as a humerus fracture in pediatric age group, the smaller the child, the greater the remodeling potential of the individual. Just look at the fracture on day one. This is a complete fracture of midshaft humerus. On day four, it can be seen to be displaced a bit. However, within 1 week to 10 days, a significant callus grows around the fracture site. Sorry, this is particularly important. This fracture hematoma organizes really quickly and then it solidifies. However, as we can note that there was a significant displacement, it gets remodeled and the fracture line and the deformity tends to disappear. This is because the two ends of the bone, which includes the proximal and distal physis, tends to grow and bring it in a normal position. Similarly, can be seen with the proximal fracture of humerus, proximal humerus fracture. It displaces completely as seen in day one. It tends to unite very well as seen in the 8-month X-ray. And at 2 years, it is hardly visible that there was any fracture present. So this is called remodeling potential. These are the two big differences which tend to occur in pediatric age group. One is a good potential to heal, and second is a great remodeling potential. The physical injuries are particularly important because this is the one of the two injuries which tend to cause problem in pediatric age group. One, since on X-rays we usually tend to have physis as a clear line, so physical injury are often difficult to identify. Second, uh, because of this, they are occasionally missed. And secondly, the importance is that if the physes are destroyed, the remodeling potential and the growth potential is disturbed. So this carries a great amount of risk of further complication. Now, there's a classification called Salter and Harris type. This is particularly for the physial fractures. It includes 5 to 6 types. However, it's not very significant to remember all of them. However, we need to know that it is that during the physis or around the physis when which the injury occurs. And type 1, it occurs throughout the physis. Type 2, it occurs partially in the physis and then goes into the metaphysis. Type 3, it includes the physis and the epiphysis. In type 4, physis, epiphysis, and metaphysis are involved. Type 5 comes in crush injuries. So this is just a basic which we should know that any injuries which are occurring tends to occur around the physis are classified according to the Salter-Harris type. The more that number in the type increases, like from type 1, type 2, type 3, type 4, type 5, the severity increases. Like apparently it seems that the type 5 is the simplest of all. However, it's a crushed injury, the whole physis tends to get destroyed. These are certain pictures showing the same classification. This is again of distal radius physial injury, and on your right you can see the medial malleolar physial injury. The treatment for physial injury is very important. It needs to be anatomically reduced so that the physis can rejoin well as compared to the other diphysial injury. In diphysial injury, obviously, it's not very important to have a 100% reduction. The anatomical reduction tends to be regained after a certain period of time. However, when it gets to physial injury, it's particularly important. Plus, it needs to be stabilized with a cast and or plus minus with wires and screws because it tends to displace quickly. Just like this. It's a physical injury which got displaced. It was reduced to its anatomical location and fixed with cross wires. This is particularly an image which is important for the fact that the pediatric age groups include a category which is called child abuse. It is particularly important to note that child who are less than 1 year of age, who are non-mobile, and who present with long bone fractures, rib fractures, and corner or bucket metaphyseal fracture. These are not common in normal fall of a child less than 1 year. So this is particularly important to understand that if a child less than 1 year presents with femur fracture, has unusual presentation, has rib fractures, and one more thing to consider is having different fractures at different age. The age of the fracture means that if there is a good callus going around the femur and there's a fresh fracture of the ribs, it means that they occurred at different levels, which tends to donate child abuse. Certain fractures which need to be considered in pediatric age group or which have a certain significance will be discussed here now. Supracondylar humerus fracture. This is distal humerus fractures, which are very common pediatric fractures, usually in the early ages of 5 to 7, 8 years. Usually, the mechanism is direct injury on the elbow. It can have associated injuries of nerve injury. Most common nerve involved is interosseous nerve injury. It can have a brachial artery injury, which is comparatively less frequent as compared to anterior interosseous nerve injury. Similarly, the patient presents with history of fall, has direct injury. We need to see for distal neurovascular status. The compartment syndrome needs to be ruled out, and X-rays are usually done, and we need to classify it. That is it a complete fracture? Is it type 1 or type 2 or type 3? We're going to discuss in this. Now, the reason for having a significant importance is that just as we can see, there's a significant amount of swelling in the clinical picture. This is how the X-ray looks like. In the X-ray, we need to see that is the distal or the proximal fragment rotated. Now, as I discussed previously, that physial injury is one thing which does not remodel or has a significant your outcome. Now, this is another important thing to look for is that if there is a rotation, the rotation tends to be difficult to remodel. And hence, this is particularly important that we correct the rotation of the bone fragment. So this is as per the treatment protocol for supracondylar fracture, BOP cast if it's an undisplaced unrotated fracture. If it's a displaced fracture with rotation, you need to get surgery done. If there is a close reduction possible, that's done and wires are passed. Otherwise, an open induction is done and stabilization is usually done by wires. Now, why wires are used? This is the cast which is usually applied. Now, these are the wires used. Now, why wires are used as compared to the screws and plates? This is important because in pediatric surgery, we need to tend to save the physis. So the more smooth the surface, the easier it is to save the physis. We tend to avoid the physis and the physial plate. However, we still use smooth rods or wires in order to prevent injury to the physis. So hence, where possible, we tend to avoid using heavy metallic material. Femur shaft fracture, this is particularly important in road traffic accidents and in patients with history of fall from height. Child abuse needs to be ruled out. This is how usually the fracture looks like. This long spiral fracture, twisting injury, different views are available. The treatment options, if the child is less than 5 years of age, we tend to get a hip spike or a cast applied. Titanium elastic nails are the recent advancement. This tends to be an easier and a smaller incision is given and the nails are passed.